Welcome everybody. At every VA hospital, you're going to find physical medicine and rehabilitation physicians. Historically, that would be related to veterans that have had neurological injuries like brain injuries or spinal cord injuries or amputations. But in my era and moving forward, I hope you'll be finding more physicians of physical medicine and rehab that really want to work with you on the pelvic floor and just general functional outcomes of trauma, in particular military sexual trauma. And I have had the incredible great fortune of working with these fabulous behavioral health folks here at Rush. We are very biomechanically trained, and many times within the course of a physical therapy treatment, people will disclose what's happening to them. And many times the therapist is sort of left with information and not knowing what to do about it. So we really partner well at the institution across the street, which is the Rush University Medical Center. But I had the joy of working with the Road Home program now for probably 5 years. I'd like us all to understand the link between trauma and things like pain, local pain, even referred pain, as well as urinary, gastrointestinal, colorectal, gynecological, and sexual dysfunctions in veterans that have had military sexual trauma. Talk about some clinical reasoning that we use as we are thinking through patients' complaints. And as we do our clinical reasonings, we're big educators, just like you all are educators about how people should be noticing how they're feeling about things and how those feelings are expressed in their body. We do a lot of education using information as much as a veteran can tolerate regarding muscle, where things begin, where they end, what job they do, which starts to really give the veteran a little aha moment of, I knew that my belly pain came after my sexual trauma, but every time I saw a physician, they either muted what I was asking or they did a test and said there's nothing wrong. So clinical reasoning helps the provider as well as the client or the patient. And then how do these pain generators start to change what you can do or can't do grossly from exercise or walking or sleeping, and then specifically for relaxing your sphincters to have a bowel movement or to empty your bladder completely, or to have your muscles become aroused when you are sexually aroused and lubricate and cause orgasm and all the other things that change after a military sexual trauma. And we'll talk a bit about dialoguing about the pelvic floor. Even though you're all going to become pelvic floor advocates and zealots, you're not going to be the one necessarily getting into the specific treatment of the pelvic floor, but just being thoughtful about the anatomy, the physiology will make you somebody who can have a moment of, I wonder if your symptoms are related to your pelvic muscles, and I can work with someone in our community that can help us with that. Also to maybe give the client some idea about what the examination can include if acceptable and tolerable. And then how do we think about treatment? And that's really mostly done by pelvic floor physical therapy. Over the last year, I would say, I'm hearing more from our cohort veterans that they have a physical therapist who does pelvic floor at their VA. There's one in Manhattan, there's one of the California VAs. At Jesse Brown here in Chicago, we have a pelvic floor physical therapist. So what does a pelvic floor therapist do? How do we find them conveniently located? Many times they locate nearby to the VA hospitals, because if you don't have a pelvic therapist, then you may have to recommend somebody outside of the program. Okay, next slide, thanks. So what's the what, the where, and the how of the pelvic floor? So, what are these muscles? Where are they located? And how do they function? So they're all located within the confines of, if you were sitting now and you put your hands on your hips, those are your iliac crests, and inferiorly and towards the midline is where the pelvic floor muscles do their work. They support our organs against gravity. They have specialized openings you can kind of see in the picture. The picture makes it look like that space is wide open. That's the anal canal, but in fact, there's specialized sphincters that control the passage of stool, and likewise in the urethra that control the passage of urine. There's a sexual function to the pelvic floor in terms of orgasm and blood flow as there is arousal, and then stability for the pelvic bones and the spine. So many of our veterans not only have pain or difficulty eliminating, they also have associated belly or back pain because these muscles don't live in isolation. They're connected to the abdominal wall, the back muscles, and the leg muscles. Next slide, please. And I should say, as you see that one reference, 1942, this is not new. We've had these muscles as the human has gone into an upright position. You need muscles to control the output. It's pretty profound, the lack of knowledge about these muscles, which is partly sociological, as though it's not okay for healthcare providers to ask questions about urinating, defecating, sexual function. But it does become something that has been muted, and even in medical or nursing or physical therapy or occupational therapy education, there's not a whole lot historically that's been taught. And it's really, I would say, over the last decade that there's expectations for teaching and for capability, which was set back pretty significantly by Dr. Nasser, who was a sexual predator, who was in the sports medicine world, to the point where Michigan State ended up with large lawsuits that has impacted other universities about teaching pelvic floor. And again, this idea that what we're doing is inappropriate. It's inappropriate if we're doing it without the consent of our patient or our clients, without informing them about the opportunity for understanding what's happening with their muscles. And again, I always tell clients, this is not cancer. In cancer care, we sometimes have to do things that are very invasive, medicines that have horrible side effects. In the setting of musculoskeletal care, we're offering up the clinical reasoning, as much as people can kind of be there and want to talk about and understand it, the chance for an examination, and then the chance for some treatment. And within the treatment realm, you can choose what you're comfortable with. So just because we examine the pelvic floor as one of the things we do, if a client doesn't want that to happen, that's absolutely fine. And we can talk about his or her symptoms of the abdomen, defecation, urination, sexual function, and make lots of recommendations by simply examining the muscles that attach externally. So I don't want you to think there's also a one size fits all. It's really welcoming people into the space to understand the mind-body connection of MST. So really, many providers have no knowledge of pelvic floor musculature function and dysfunction, even if you have local organ expertise. So gastroenterologists or colorectal surgeons or gynecologists or urologists don't necessarily study the muscle, what happens with scar, what happens with the inability to relax. And so they oftentimes rely on traditional diagnoses like, well, I'm going to get an ultrasound. You have pain in your left lower quadrant. Oh, the ultrasound was normal. So therefore you have no pain? Therefore we need to keep figuring out what's wrong. And so many times there's not a framework to consider muscles, nerves, joints. You can't see a tight muscle on an image. So if you did an ultrasound or you did an MRI, you're not going to see the muscle. You need to listen and, if able, examine the patient to understand what's going on. And these also cause problems for, as I said, GI, GU, urological, colorectal, and all the other symptoms that bring you into the realm of these other physicians who are sort of thought to be the yes or no decision makers. And yes, we had heard earlier with MST, but across all of care, female referrals are much greater than male referrals for pelvic floor assessment and care, as though, oh, men don't have pelvic floor muscles? Well, sure they do. It's interesting to the point of where the American Physical Therapy Association, women that, mostly women, there are some male providers that get expert training and take tests. They're called women's health physical therapists. And this is because the origin of caring for the pelvic floor really was sort of carrying and delivering a baby. So it was a lot of women that were showing up with pelvic floor issues that really weren't being well managed. And PT said, we can help with this area. So we need to change our language even around women's health PTs take care of pelvic floors. Pelvic floor physical therapists take care of pelvic floors. Next slide, please. So how do you develop a template of how and when to refer a client for some pelvic floor providers? At Rush, it's easy. When folks come for the Road Home program, the nurses and the intake folks talk about the pelvic health treatment that we have available and whether people want to opt in or not. They want to tell the client, what does the assessment look like? And then you want to figure out in your community, who could you partner with to provide evaluation and treatment, since you don't have this team where all of you are. So definitely a pelvic floor provider, and I use that term broadly here. Not every physical medicine or rehab physician is interested in or trained in pelvic floor. That's an area of my great interest, and I work with a cohort of people locally and across the country, but they're not as easy to find from a physician perspective as it would be to find a physical medicine or rehab doc that takes care of back pain. Pelvic floor physical therapists really do have a larger network, and they are very linked into other providers in their community. So let's say in your community, you find a pelvic floor physical therapist. I will say it now and remind you later that the American Physical Therapy Association, the APTA, on their website can lead you to a pelvic therapist, but you have to search for a women's health physical therapist. So again, kind of crazy. It goes back to the, sort of the history that this is somehow offered to women more than men, which is not appropriate. And those physical therapists in your community might be able to then link you to a physician who they've had good success with. Sometimes it's a pain physician who's able to do some local blocks or other medication management that the physical therapist needs to do her work. And then how can you prepare the patient? You can differentiate that when you see a physical therapist, they're going to examine you, they're going to talk to you, they're going to examine your muscles. And then if they are concerned that the muscles of the pelvic floor are involved, they might also include a pelvic or a rectal exam, which is not like the pelvic exam you might be getting from your gynecologist, or if you're an older male, it's not like the rectal exam you're getting for your prostate. It's actually an examination that includes muscles. This would be described, we would show images or a model, and we would offer this. You could have someone with you if you wanted to have somebody with you. If the exam starts, we can always change our mind and change our path. So it's one of these kind of opt-in if it feels like the right thing, if it makes sense to you, and you feel like you're being well educated. And I sometimes use the analogy that I'm the container doctor and I work with all these organ doctors. And the organ doctors just sort of don't think about the container as a pain or a functional problem generator, which is exactly what a rehab doctor thinks about, is your overall function. How do we meet you where you're at? And what are your goals, and how can I help you get there? Okay, next slide. I assume we're taking questions at the end, but keep some questions in mind. I put this slide in specifically to remind you and me to think about males with pelvic pain, because chronic pelvic pain, there's lots of literature, mostly coming out of the female literature of urogynecology and gynecology. Men have pelvic floor muscles. Men have pain. Men get labeled with diagnoses that do not describe what's going on, and then they're given tests that are supposed to be either positive or negative, and then they're pushed away if they're negative to say, I don't know what's wrong with you. Or there's some lab work we're going to do. So if you have white blood cells, we're going to somehow call it an itis, an infection. Men get, I would say on average, 5 rounds of antibiotics before they may luckily find their way to me or a urologist who thinks about muscles or a physical therapist. And usually it's your prostate, period, as though in the male pelvis, there is one organ that urologists think about, which enlarges when you're older. Now, when you're 30 and you are revealing that you had a sexual trauma, to sort of try to put the onus on the prostate to be yes or no the pain generator, which of course, if you're 30, the tests come back normal. So the etiology, they will say, may be related to a psychological stress or dysfunction, but then they want to always tie it back to something that you can test in the medical center. So patients oftentimes need to keep advocating for themselves. And one of the things that we had more time to do when we have our longer 3-week IOP was to actually do some role playing, to say to go home to your physician, okay, I met this physician who told me that these are the muscles that are having problems, and this is why I'm having trouble with dysfunction, and I need to be referred to somebody who can help me, which is a pelvic floor physical therapist. And so they've had this experience of being sort of blown off or treated as though, oh, here comes Mr. So-and-so again. I don't know why he's in the office. And if they can't find the source, to sort of, again, say there's nothing wrong, rather than thinking, is there a particular tissue issue? And we could sort of just, start to frame up what's wrong and what to do to take care of it, and change the position of the patient in terms of their pain or their functional problems. Okay, next slide, please. So When you're talking about the pelvic floor, again, many times it's a new area, and in particular with our MST cohort, there's a lot of sensitivity. We already mentioned that everybody has to have the same level of sensitivity. Listening to a patient list their symptoms, the nature and the onset is very helpful to me start thinking about the clinical reasoning and what's going on. So it's really important to hear it come from the person themselves. You can use things like pain scales and visual analog scales to sort of help you decide whether your interventions are helping. So if you have a pain scale, when you meet the client and then you have an intervention, it's nice to know that the pain is heading in the right direction, as an example. It's nice to know what things make the pain go higher when you're starting to think about what tissue is you know, if it hurts to sit for a long time, what particular tissue is under stress, let's say in that sitting. There's other larger things, scales like the International Pelvic Pain Society scale, which is very comprehensive, which again can help us if we start thinking about maybe some research on what we're doing and how it's helping large groups of people. Having somebody point to the location of the pain, it's really important. If somebody sort of points to their entire abdomen as hurting, rather than it hurts right here, it starts to help me realize more about, is it a local muscular phenomenon, or is it more of a centrally maintained pain where there's a large referral throughout the entire abdominal area, for example. Talking about what helps things get better and what makes them worse is extremely helpful in terms of, again, thinking about locations of muscles, functions of muscles, which nerve is in the area, how do you relieve something by changing positions. Talking about sexual history, abuse history, and other trauma history has been something that I have, been able to evolve as a non-behavioral health provider through the help of my colleagues. I'm looking directly at Vanessa in particular. Dr. Tyrone has been very helpful for me for things like saying, the medical literature shows that sexual trauma is associated with pain and dysfunctions. Has anybody ever put something in your vagina or your rectum against your permission? So I'm norming why I'm asking the question, and then I'm asking a very direct question, and I'm not sort of couching it in something I'm not comfortable with. I would say when I was a young rehab provider, I would say something like this. Okay, now I'm really uncomfortable asking you. Can I ask you one more thing? And if you don't want to tell me, that's okay, but have you ever been raped? Okay, I've already said that this is abnormal for me to ask you. I'm not comfortable asking you. And what does rape mean? So for me in my area, and again, keeping it real and keeping it clinical, I want to figure out what's going on with your muscles. And I want to know if anybody's ever put something in these openings without your permission, because I know that the literature would say if that's happened to you, you're going to have trouble with pain, possibly urinating, possibly defecating, possibly with your sexual function. So now I'm offering this as a moment to share information together, to say you're not the only person, and to also let them say that they do or do not want to disclose in this moment, but to plant that seed. So for me, it's a much more positive interaction. I feel better, which shows on my face. I'm sure that hopefully the client feels welcomed into that space. And I would say that our physical therapists are finding out people do disclose to physical therapists. They come in for back pain, and they're talking about things. So as a physical provider, we need to have the skill set, and I'll talk in a minute about a trauma-sensitive approach that we use at Russia. We taught providers, which really was good for outcomes for us and hopefully for our clients as well. Other things that might clue you into sort of ongoing problems with defecating, urinating, sexual function is how do the organ systems themselves then feed into these over-messaged muscles? So during your menses, as an example, when your uterus fills with blood, it's not very happy, it's a noxious input, and then that organ, the uterus, tells the muscles to tighten up. So for that last 5 days or so, and as you start to menstruate, your muscles are tight and then they start to loosen up. So how does the organ system then feed into this? And I really learned pretty quickly that besides the MST experiences, veterans go overseas, they eat food that they're not used to, they defecate in public places, or they hold on to their urine or their stool for hours. And so all these things only sort of serve to increase their problems. And many of the combat veterans that IOP veterans that I see have lots of pelvic floor urinary defecatory problems. So anyhow, there's this sort of feedback loop that just makes things keep getting worse and worse. More providers get into the mix. if you're lucky and you advocate for yourself in the system. And these providers do tests that don't help with distinguishing the cause, and in fact are very invasive and very uncomfortable. So a colonoscopy comes back normal, but now the patient feels worse because we've just put air and a big tube into their system that's already too tight and already they're bloated or et cetera. So also, you know, how do we think of intimacy again as a role, a functional role that we all have in our lives that we can participate in? And even things like, for me, using the analogy that when I put somebody back to, I'm a sports medicine doc, when I put them back into their sports, I don't put them into a game and, you know, 9 innings of a softball game where they're playing shortstop. I might have them throw the ball off the wall or play catch, right? So how do you think about your own system and figuring out for yourself what works before you bring a partner into the mix? So there's all sorts of really helpful ways to give control back to the client or the patient. Next slide. I'll go talking on and on, so you guys make sure I'm watching the clock too. This is my area of passion. It's just underrepresented and undertreated. So this is a picture from a book or a mini monograph that was used to teach, you know, physicians. Here's a disrobed patient. She is looking uncomfortable. The practitioner is not looking at her. I mean, I've heard horror stories of not just one practitioner, but multiple practitioners in a room in a way that's completely unacceptable and not how we think about this. Before I even get to the physical exam, I'm going to be explaining to a dressed person what I want to consider, how I might, you know, palpate muscles. So I'm going to use a model, if that's okay. Again, asking somebody, will a model cause you to be uncomfortable or trigger, or is that okay with you? Great, okay. And then using the model to show the muscle, where does the muscle begin? Where does it end? What's its function? How might I insert my finger? Not to do a general gynecological exam, which is with an uncomfortable speculum, which takes, you know, tissue from your cervix. If it's a pap smear, it's a digit. It can be removed immediately if you're not comfortable. So we're going to get consent, but also know that we can stop this in any way. We can change the position you're in if that's making you more or less uncomfortable. In a different scenario, we see women that have trouble going for their gynae exam and they come to physical therapy and they sort of get to know the speculum. They see it as not this cold thing that's brought out of, you know, out of a cupboard somewhere. I mean, so sometimes there's not only the MST, but there's other negative experiences with healthcare providers causing, you know, PTSD from a physical exam perspective. So getting consent, you can have someone in the room with you if you would like, of course. Letting them know that the abdominal pelvic exam could be provocative, asking, has this been the case before? What can I do to make this more uncomfortable? Acknowledging that flashbacks can occur and to let me know, and we can take a breath or we can change the procedure altogether. Consider positioning so I can see his or her face while I'm doing the examination, and actually empowering the patient to decide on, is it going to be a hand up? Is it going to be, can you stop? Whatever plan is to change the direction as needed. Next slide, please. So we then switch to a gown, if that's okay, because it's really helpful to me to get some knowledge around, you know, generally speaking, how is the patient altering the way they stand, the way they sit, the way they move, and watching their face? Do they have normal motion of their low back? Do they have lower extremities that move well at the hip and the knee? Do the muscles look the same? Is there any side where there is wasting away of one side, which then makes me want to include some type of neurological impact, not just a myofascial or muscle impact? There's really commonly muscle pain in the glutes, the piriformis, which is just deep to the glute, and then just deep to the piriformis lives the pelvic floor, yet we teach providers about the first 2 layers and we completely pretend like the 3rd layer doesn't exist. Anyhow, there's also muscles on the inside of the leg called your adductors that might be very tight in regards to especially trauma and the way that you are sort of protecting yourself. And then there's a big muscle that comes from your back called the psoas muscle, and it attaches to the iliacus muscle, and the 2 of them lift your leg up. So every time you step forward, you use your iliopsoas. Every time you step up on stairs, every time you stand on one foot to try to put your leg in the other pant leg, you use your iliopsoas. So You've already heard from the person what things are in trouble, what's not working so well. And then there's all these layers of abdominal muscles that get completely missed when you think about how we diagnose GI problems. And these muscles, just like your trap muscle or your glutes, they can get trigger points. So there's all kinds of ways to examine the abdominal wall. And then a lot of clients have had surgeries or trauma, so scar tissue from surgery can impair the ability of the abdominal wall to expand and contract. It's really fantastic to be part of a group where clients are learning yoga and yoga breathing and things like the astronaut position for mindfulness meditation, which means you lay on the ground with your legs bent and your feet up in a chair, which completely puts your psoas muscle in a relaxed position. So throw a little heating pad over your abdominal wall and your psoas while you're doing your mindfulness meditation. And that's like a 3 for 4 or 5, a 6 for 1 in terms of what kind of benefits it can help our clients with. Next slide, please. The physical examination of the pelvis itself. Again, there's maybe some scary pictures to people on the right there. This is not a slide I would use with my clients. This is to teach you about what I'm thinking about when I examine a patient. So if I think someone has carpal tunnel, I know that the median nerve supplies just these 3 fingers. I know that the muscles of the median nerve includes this thumb muscle. I'm going to resist the thumb motion. I'm going to look at that muscle to see if it looks wasted away. I'm going to palpate to say, do these fingers feel number than these fingers? This is the same thing I need to do in the pelvis. What sort of scar is there from the trauma itself and or labor delivery, or let's say prostate surgery in a male? Is there any prolapse, which is when the tissue weakens and the organs start to protrude out, which puts its own amount of stress on the pelvic floor, regardless of trauma, no trauma? What's the neurological function? If I lightly stroke, does it seem the same on each side? You can use a Q-tip to see if there's actually the feeling of pain instead of just a light stroke. And then what about strength? With my finger in the vagina, can the patient squeeze and let go? These are just simple, straightforward things we do at any part of the body when we're trying to figure out, is there a nerve impairment? Is there a muscle impairment? And just even some reflexes. If you lightly stroke on the inside of the thigh, you should see the sphincter of the rectum tighten up. So these are all things we do to look at the health, the current status of the neurological function of the pelvic floor, because unfortunately, trauma can cause a change in neurological function. Next slide, please. So again, if I'm going to do a physical exam of the vaginal muscles or the rectal muscles, I want to be able to see the patient's face, and I want to be able to think about, where does the pelvic floor muscle begin and where does it end? So for instance, the pubic bone, which is that very tender bone, kind of right under where you zip up your blue jeans, and your sacrum, which is the triangular bone at the base of your low back. Those are the 2 anchor points, and the muscles sling from front to back, and they have a right and a left sided. And as I'm palpating, depending on the patient's sense of, would you like me to tell you what I'm doing versus are you better just relaxing and in your own head and taking some deep breaths? But I will be palpating to see if there's a difference on the right versus the left side. We sometimes educate with a clock face analogy. So if somebody is in, let's see, the position of stirrups, I don't use stirrups. I find them to be, I don't know what, horrible personally, but their knees are bent up. If you look at the perineum or the pelvic area, the pubic bone would be like 12 o'clock, the sacrum would be 6 o'clock, and we use a clock face analogy to talk about 3 o'clock is on the left side, 3, 4, 5, 6, and then 7, 8, 9 will be up on the opposite side, so that we can start to associate, yeah, that's the pain I feel when I'm being sexually active, or that's the pain I feel when I'm trying to relax to pee. And you can, just like you might say in someone's neck, is this the pain you feel after you've been on your computer for 6 hours? It's the same kind of concept. And again, if there's problems with posterior pain, coccydynia, which is a painful tailbone, troubles relaxing to defecate, I may also do the same kind of digital examination around the rectal sphincter and muscles to see if I can corroborate pain and dysfunction and then make a path forward for treatment. Okay, next slide, please. As I mentioned a few slides ago, trauma-sensitive care is critical and not necessarily part of your usual medical education, quite honestly, and physical therapy education. And it integrates this idea that we're all compassionate medical care providers, but we don't really know necessarily psychological best practices. with trauma survivors. And again, must be applied consistently across the whole Road Home program, and in particular, educating us up. One of my other faculty members is a traumatic brain injury expert, and he also comes over and does assessments for TBI and needs to be knowledgeable about trauma-sensitive care. Short-term goal is to reduce new trauma or trauma exacerbation at the visit. And as I mentioned before, we hear stories all the time of medical care providers inducing additional trauma. And the long-term goal is to help the patient have a safe and pleasurable sexual experience, as this idea that being insensitive and not sort of framing this up as, you know, this is your long-term goal and we're going to get you there, just like we do with an athlete. We're going to get you back into the sport that brings you into my door that you cannot participate in, so that people know that there's nothing that's permanently wrong because their muscles are too tight. We expect that this could happen. These are the outcomes we see, but there's not necessarily a permanent path to, you'll never have pleasurable sex, you'll never be able to, you know, bear a child if that's what you decide you'd like to do. Okay, next slide, please. So, you know, we agree that the Rush Pelvic Health providers were compassionate and were trying to be responsive to patients, that standard physical therapy could trigger these symptoms because of these invasive techniques. And that they frequently spend more time with patients, allowing greater communication. So the opportunity was they're hearing about these traumas, and the limits were that we really weren't trained, even though we cared about it. We didn't have the sort of training and the realization that we could be triggering as much as we were helping. Next slide, please. So we did an intervention that was both for the clients and for the physical therapist, which again, I think interventions that are multi-targeted are always really excellent. For the physical therapy, interventions on the right was techniques to reduce pelvic floor hypertonicity. So just like you might do a progressive relaxation with your neck muscles, you could do similar things within the context of your physical therapy appointment to help a client tolerate or experience what was happening. Yeah, how to assess for a sexual abuse history, how to reinforce use of assertive communication for our clients, how to reinforce use of anxiety reduction at the moment, you know, in the moment of the exam or the treatment, and then providing positive messages about sexuality, which I already mentioned. And at the same time, the patients in the study were learning about psychoeducation, the kind of mind-body connection, how to do relaxation skills during treatment and outside of, how to communicate assertively, know that it was going to be well responded to, not like other providers that might sort of say, you know, be quiet for a minute while I finish my exam. Those sort of things that we hear all the time. What about pain management, and how do you ask about, you know, this treatment's uncomfortable, can you help me with other ways to manage my pain? Which oftentimes then the physical therapist would come back to me to say, what else could we do topically or orally to help with pain? Challenging sexual myths, again, this sort of idea of there's one way to do things, or that you're always going to have trouble with sex, etc. And then, you know, how to sexually communicate. So as you're learning things about your body, how do you bring others in your lives, in your intimate life in, and they could help learn and understand. So we called it the RESPECT Study, Restoring Emotional, Sexual, and Physical Empowerment through CBT and Trauma-Sensitive Care, a Chronic Pelvic Pain Intervention. And let me tell you, we need as many chronic pain pelvic interventions as we can get, because chronic pelvic pain is really a problem, and it's with our MST folks as well as others. In fact, there might be somebody on this call right now. Oftentimes when I speak, someone comes up afterwards about themselves, their sister, their girlfriend, you know, whomever. So it's common, and it's not talked about, and it's missed. And this is very helpful. So 7 sessions cognitive behavioral intervention began before the initiation of physical therapy, so that both we were ready and the clients were ready, and it came together. Next slide, please. So if you have the chance to cross-reference each other, it's very helpful. The other piece I wanted to bring up is that it's not a uni-system problem. If you have a problem with one of your openings, you have colon cancer, and now we've done a surgery to your rectum, guess what? Your urination and your sexual function will change. It's kind of like if you, I don't know, if you had a problem with your upper trap muscle where it attaches behind your ear and was causing headaches, it's also going to pull on the muscles that go down to your shoulder. And so if you show up with the shoulder problem, I'm not going to image your shoulder. I'm going to be listening to the connectivity of this muscular system. So if you have a problem with sexual assault, no matter where, how, the entire sling of muscles from that pubic bone to that sacrum are at risk of having too much tension. So we know that as providers, and I am the one in our pelvic health clinic on the Rumsey, Rush University Medical Center side of the house saying, send me all of your people with problems defecating, urinating, lubricating, because they're all going to be related. We also took a look at veterans who experienced MST. They were in our cohorts, and they had had a prior childhood sexual assault, and they demonstrated worse PTSD symptoms. There were 174 veterans who were seen for pelvic exams through this mechanism where, again, they're offered to talk to me and then offered while they're in with me to have an exam, and I can make some recommendations for physical therapy. About half of them had a history of at least one childhood sexual assault, and most, about 45%, most had either 4 or 3 systems involved, and those systems included urinary, defecatory, sexual, and let's just say pain in general, so pain. So about half had all 4 complaints in all 4 areas, and another third had 3 systems involved. Interestingly, the history of childhood sexual assault was not found to be statistically associated with the difference in the number of involved systems, and we had postulated that those with sexual assault in childhood would likely have more systems involved. We didn't see that difference, but I can just say that 45 plus 35 means, 80% of people in the cohort had, more than 2 systems involved. So again, the idea that you see a urologist or you've gone to the gastroenterologist and they've cleared you from the, why you're having your symptoms just doesn't make sense. You need to have an integrated approach to the pelvic floor in regards to pain and function. And this is a poster that we're putting forth in an upcoming meeting and hope to get a manuscript out there as well. Okay, next slide. Okay, so again, what are some of the patient empowerment tools that you can, along with the recommendations to see a pelvic therapist, you can also give your clients acknowledge as a chance of triggering the PTSD, and consider the likelihood of avoidance, not only in that one moment when you make the recommendation, but the literature that says that folks that have had sexual trauma don't go for child care visits when they're pregnant, and all sorts of other things. There's association with childhood sexual trauma and having diabetes or metabolic syndrome later, obesity. There's all kinds of ways that this is going to show up in people's medical health. And you at that moment can remind folks, this may seem like it's a small step. If you're ready, it's a really powerful step. They need to advocate on their own behalf. I mean, no one sits around that I know of talking about their painful vaginas. I mean, that I've been around, and I sit with my friends and talk about a lot of stuff, and I'm a provider. It's just not necessarily the social norm. And once you teach people and they do get other people in their lives, they might say, oh my gosh, I talked to my sister and you won't believe it, but this has happened to her and she's also having trouble. And even providers are going to lack the knowledge, and they might make their provider uncomfortable. So we actually give people like a sheet of paper with here's the data that says if you've had sexual trauma, you're likely to have multi-system involvement, and here's some information about getting this evaluated and treated, because you might be the only one in the room, I tell my veterans, who knows about these muscles, and you're gonna have to go home and advocate for yourself. And you might make other people uncomfortable, but again, the reasoning, what we're doing is just very similar to what doctors do in all kinds of areas. They just are not knowledgeable. And when you call back after your test is normal, the way the system works is your test is normal, see you later, rather than that test was normal, who else can we bring onto the team that can really solve the problem and work together with us? Okay, next slide. Okay, I have a few references, but there's a huge literature. This is not anything new. There's a disorder called vulvodynia, where the vulvar area is the non-hairy opening of the vagina, which includes the labia majora and labia minora. And in 1887, someone talked about vulvodynia. Yet, again, people don't talk about this from the perspective of, how do you think about an area of the body that's having abnormal sensations? What are the other ways that nerves work, oddly or in a way that's exuberant? They sort of say, oh, it's in the vaginal area. We're not going to talk about it. We're not going to think about it. So this stuff is is part of our anatomy. It's a part of our life's functions. The pelvic floor physical therapy experts that are available through the American Physical Therapy Association website. Again, it's the Women's Health PT Locator. And I think nowadays you could literally Google pelvic floor physical therapy in your community and you would get a large response. Some of my male clients have to go home. I tell them you have to call and figure out, do they take care of men and women? The way pelvic floor physical therapy is taught, you start with sort of the female anatomy and the common things like labor and delivery, gynecological surgeries, and then you layer on the male anatomy, you layer on gastrointestinal problems, you layer on post-cancer patients, be it colorectal, gynecological. So a new provider may not be the person that you need, nor will she have the kind of skill set that you need. So there's a bit of homework that needs to be done as well. Before I retire, it was my goal that every VA has a veteran physical therapist who knows the pelvic floor, and male, female, knows MST well, and that we can have that provider really handy and available to help. But in the meantime, my national colleagues, there's many that treat and are near the VA systems, and they understand that that's a source for pelvic floor issues for certain. I think that's my last slide, right, Ashton? Okay. So I haven't been watching the chat, so let me go over there and take a look, and you can start looking at some questions. International pelvic pain scale. Go ahead.
Oh, sorry. I was just going to say that Ashton and I have been compiling a list. So if you miss any, we got you.
Okay, great. Okay. So anyhow, the International Pelvic Pain Scale is, as I believe it's available, publicly available. There are some scales that you have to, pay for or ask permission for. So I think you could just Google that, and maybe I see Vanessa has her head down. Maybe Vanessa could pull it up for us. Let's see. Is there a chart or resource that lists common medical issues associated with sexual assault? My first response is there are so many, it might be hard to list them all. And I'm wondering if there is anybody that's done a sort of general overview of this sort of medical, again, there's metabolic issues related to sexual assault in the long run. There's momentary, there's acute issues related to sexual assault medically in terms of trauma, laceration, etc., infection, STD testing, and then there's these sort of subacute and then chronic issues related to sexual assault. Oh, thanks. There's the International Pelvic Pain Scale.
Literally just Googled it. Super easy and free.
Great. Questions? Love to know if Dr. Dugan has a specific self-report measure that she recommends to assess pain. A lot of so the International Pelvic Pain Scale is really long and kind of a commitment. The visual analog scale is one that we sometimes use in studies. It's not very satisfying. The numeric rating is another thing that people can self-assess. And there are separate, like we've tried to put together, there are separate scales, sort of urological scales that include pain, or the gastrointestinal folks might have scales about pain or constipation. So it kind of depends on what you're interested in, but I think monitoring a number is one way that we can say 0 is no pain and 10 is the kind of pain that you need to go to the emergency room for. These numbers, a 10 is specific to me, because if I've had pelvic pain for 10 years, then to have to go to the emergency room, isn't going to happen because I've been through the ups and downs. Whereas somebody who's new to pelvic pain may be showing up in the emergency room thinking that it's a 10/10 for them. So again, that numbering system is at least kind of specific to an individual.
I was going to say as well, like there are probably differences in the detail, like Dr. Dugan might need to assess as a medical provider versus like what we might need to assess in order to at least like educate the patient or like give them referral resources. So when we speak with potential IOP patients and we're doing our intake interviews, we ask them like pretty simple questions like, do you have any pelvic pain? And so a pelvic pain would be any pain that you experience in the area between like your belly button and the bottom of your underwear, basically. And then kind of as a follow-up, we can ask questions like, the reason, we also usually give like a introduction, just like Dr. Dugan talked about, right? The reason I'm going to ask these questions is because we know that a lot of veterans have, pelvic health concerns or pelvic pain. We can also ask questions like, do you have trouble doing things like kind of peeing, pooping, or have like pain or discomfort with sexual activity? And so as the mental health care provider, those questions often like are enough to kind of give us something to go on to know which patients might need to see a Dr. Dugan or like a pelvic floor physical therapist.
Yeah, and I see this thing, is there a chart or a resource that lists common medical issues associated with sexual assault? I don't know that I've seen that. It doesn't mean it's not out there. And if it's not out there, then maybe we could help with creating it. There are studies that say if a woman comes into a gynecological office for pain with intimacy, she's more likely to have troubles with defecating and urinating if she was sexually assaulted. So those are things that we feed back to the gynecologist's office who is treating her for her presentation of pain with intimacy to say, are you asking questions about, urinating and defecating because they're likely to be impacted? Well, first of all, are you asking questions about, has anybody ever put anything in your vagina or your rectum without your permission? And then associating that with the likelihood that you're at higher risk of not only, vaginal issues, but urinary and defecatory issues as well.
It can also show up with like other types of activity, like Dr. Dugan, feel free to add, but like some folks with pelvic pain have difficulty sitting for long periods of time, like at a work desk. So it doesn't, the pain doesn't necessarily show up kind of like just with sexual activity. It could be kind of more of these like everyday sorts of tasks or positions.
Absolutely. And most of our veterans are sent to kind of an orthopedic model if they have back pain or pain sitting or pain in their hips. And if the orthopedic model doesn't, again, just include this layer of muscle, I mean, honestly, these muscles exist, they're just not taught. So you now know about these muscles. So it may be that little aha moment. You've already been for care. It hasn't gotten better because perhaps the differential diagnosis was too short and this needs to be included. And so helping people, one of the things I do a lot is to help people understand, what I think it is and what I think it's not. So going through carefully, I know you had an MRI and there's a degenerated disc at L4-5. You're 50 years old, so more than half the population has a degenerated disc. I see no other signs or symptoms of nerve involvement from that disc. So let's just take that off our list. So many times by eliminating these other worries people get, oh my gosh, did you see my MRI of my disc? That there's another piece of, okay, you did your homework, you've seen the right person, it's not what's causing your problem. So that feels better than somebody sort of blowing you off without explaining, what it was about that image or that test result that does or doesn't relate to, how you're kind of coming in the door with the complaints that you have. And again, these veterans fall off of Humvees, they crouch. I mean, they have all kinds of other reasons to have, chronic musculoskeletal problems that are then further exacerbating or, the basis for their additional problems after their MST. Well,
Also, to kind of tie some of this a little bit back to the work folks might be doing in CPT, oftentimes folks can have kind of maladaptive cognitions about sex or about pain that have kind of impacted how they've dealt with this over the years, right? So it's not uncommon for folks to have beliefs like it's normal for sex to be painful for a woman, or sex is something I'm obligated to provide my partner. Sex only counts if it involves a penis penetrating a vagina. And so some of these beliefs, if they're held really rigidly by the patient, can contribute to them like kind of ignoring the pain And so again, like part of our role, and this can even be done in the like intimacy section of cognitive processing therapy, can be to educate patients to help them work on some of these beliefs. And that can kind of open the door and create more willingness to actually like seek care or to be assertive with partners to resolve some of these issues.
And there's just another reminder of how incredible it is to work as a group together to be able to, you know, not only make better diagnoses, but then to reinforce, you know, how assessment and treatment can be helpful. So I do encourage everybody, thanks for your attention. I wish I could see you all. I'm a people person. I'd be walking around the room and making eye contact. So I hope that you've learned a lot today. And if I can be of any further help, or if you want to reach out to your local pelvic floor physical therapist, she or he, mostly she, will be extremely helpful to you in kind of, you know, finding a path for your clients and your patients. So good luck.
We do have another question, Dr. Dugan. It says, given the avoidant nature of survivors of sexual assault, I wonder how many people delay medical exams.
All the time. And I think, again, you know, welcoming people to telling their story and giving them some, you know, grounding about why they might be having symptoms and what tissue might be the source of the symptoms, and the ability to have an assessment if they're ready for it. And sometimes they're not, and it's not the first visit that I even do the physical exam. So yeah, so I think it's a real problem, but not one that can't be addressed with patience and understanding.
We
Okay, so
also
while we're
do
doing,
have pretty good like uptake exams within our program. So I think it's around like 70% of veterans actually volunteer to have a visit with Dr. Dugan. And they're given the option, like Dr. Dugan said, to either kind of just do an interview and learn more about things, or to receive a physical exam, which could include some invasive components or not, if they don't prefer that. And so like the vast majority of that 70% who meet Dr. Dugan also do complete a full kind of internal pelvic exam. And so I think that also suggests that if we can provide folks with like the appropriate psychological support while they're engaging in this type of medical care, that it like can be really well tolerated.